till the slides are being set up. Ludhiana is very special to me. I did my graduation, my post-graduation from there in medical college. And in the audience and on the dais I have two teachers, Professor Rajesh Mahajan, who taught me, literally caught hold of my hand and has taught me the ventilator settings, how to interpret ABGs, how to put in a central line. I still remember he taught me how to intubate a patient. So thank you, sir. Professor Gautam, though in our time we didn't have much interaction with anesthesia, but I still remember him. He was the most sought after person in anesthesiology in DMC at that time. I just missed Dr. Harmeet Huria, who is a very good friend and a very good teacher. So sir, I am here because of you. I also want to thank Dr. Viksa Suri for giving me an opportunity to come here and feel worthy enough myself that I can deliver a lecture here. Lastly, I want to thank Professor Sandeep Puri, Dr. Pannu, Professor Avasti, who are my teachers, Dr. Veg, who are my teachers, and Ludhiana has always been very special. And delivering a lecture is always a dream here. The topic given to me is fluid resuscitation in ICU. If you see the ICU burden in US, between 2000 and 2005, the annual critical care medicine cost increased from 56.6 to $81.7 billion, representing 13.4% of the hospital costs, 4.1% of the national health expenditure, and about 0.6% of the gross domestic product. The five main primary ICU missions were respiratory insufficiency, post-operative management, ischemic heart disorder, sepsis, and heart failure. And with advent of time, we have now CCUs, we have trauma ICUs, we have medical ICUs. So all of these, this was basically a conglomerate data, not a data from specific ICUs, so medicine ICU alone. So this is the data from Addis Ababa, not called a developing country now. And infectious disease constitute about 30% of all ICU admissions. DK was the most common, second most common MI, and severe sepsis. Everybody knows what Survival Sepsis campaign. I thought I should start my talk with Survival Sepsis campaign. It is updated every 2 or 3 yearly. Last update, small update was in 2015. The major revise was in 2012. It's a global program. It has the standards from many of the associations all over the world. These recommendations are intended to prove guidance for clinicians caring for patients with severe sepsis or septic shock. And everybody knows that the goal-directed therapy, that is within first 3 hours of time of presentation, to measure the lactate levels. These are major changes in the 2012 guidelines. To obtain blood cultures, administer broad spectrum antibiotics, administer 30 ml crystalloid for hypertension and or when the lactate is more than 4 millimoles per liter. And in the 2015 guidelines, they have updated the 6R bundle also, applied by the nurses. In event of persistent hypertension, they have advised to reassess the fluid status, and we can do either by focused examination, measure the CVP, measure the central venous oxygen saturation, or we can even do a bedside cardiovascular ultrasound. Well, if I have to finish my talk, I can finish here. The crystalloids have been given. There is no mention of starch. There is no mention of albumin. There is no mention of blood. So we can have tea. I know all of you are hungry and all of you want tea, but I have to justify 30-minute talk. I have to justify that I have been brought here to deliver this lecture. So I have to. So in the next about 15 minutes, I will try to cover all the basics of all the types of fluids, how to monitor fluid in patients in ICU. The topic, my discussion would be the types of fluids, the role of various measures, how we can guide the fluids in patients of sepsis or patients in various ICUs, which could be either measured by CVP, whether it's required or not, dynamic stress for the focus examination. Coming to intravenous fluids, every chapter, every article what IV observation in 1832, he says, having inserted a tube into the basilic vein cautiously, I anxiously waited and watched the effects. Ounce after ounce was injected, but no visible change was produced. Still persevering, I thought she began to breathe less laboriously. Soon the sharpened features, sunken eyes, fallen jaw, pale and cold bearing the manifest impression of death signal began to glow. There were signs of recovery. With the returning of the pulse which had long ceased, when 6 pins had been injected, she expressed in a firm voice that she was free from uneasiness, actually became jovial. And the last, all she needed was a little sleep. Her extremities were warm and every feature bore the aspect of comfort and health. This is exactly the gratitude, the sense of relief which one feels after if the patient has been resuscitated. Any patient in ICU has been resuscitated successfully. We go back to the history of IV fluids. First use of IV fluids has been reported way back in 1834. Ringer was introduced in 1876. Acetate was also introduced in the same year, but the real breakthrough came in 1950 when an anesthesia resident discovered the Rochester plastic needle, which was a needle-slit plaster pattern. The vein flow which we used, this was the first time that a vein flow was used in world history. The two types of fluids, crystalloids and colloids. An ideal resuscitation fluid is which has a predictable and sustained increase in intravascular volume. The chemical composition is as close as possible to extracellular fluid. It is metabolized and completely excreted without accumulation. No adverse metabolic or systemic side effects, and it is post-effective. And ladies and gentlemen, I have no hesitancy to say there is no such perfect fluid available for clinical use as on it. Crystalloids, the range from, sorry for the slide, I should have made a very good slide. Range from normal saline, dextrose, ringer acetate or ringer lactate. Major determinant are the concentration of sodium, which can range from 154 milliequivalents in isotonic saline to isolate P, which contains about 25 milliequivalents. And I'm mentioning about isolate P because this is fluid, which is the fluid nowadays. And also potassium concentrations, which range from 35 milliequivalents in isolate M to about ringer lactate, which has about 4 milliequivalents of potassium. A word about normal saline. Everybody would have used normal saline in his or her practice. Any clinician would have used it. It is the most common used crystalloid solution on global basis. It is normal, exactly 0.9%. It contains 0.6%, but it is considered 0.9%. It contains sodium and chloride equal concentrations, which makes it isotonic. But it has said that administration of large volumes leads to hyperchloremic metabolic acidosis, and this sometimes leads to renal dysfunction or also immune dysfunction. Some innovations have occurred in crystalloids. To negate the large volume normal saline, the fluid overload, there were some studies of using small volume crystal resuscitation with hypertonic saline. But majority of the studies show that unfavorable results in patients, especially in patients with traumatic brain injury. Then there came a concept of balanced of physiological solutions, that is plasma light. It is a hypotonic solution. The instability of the bicarbonate in this solution, because of the plastic containers, we have to add ions like lactate, acetate, gluconate, and malic, and these cause sometimes complications like hyperactivemia if lactate is added, cardiotoxicity if acetate is added, and microthrombi when citrate is added. It is generally indicated in patients undergoing surgery, patients that have ketoacidosis, and even burns. In burns, because of the capital leak, there is a strategy of permissive hypovolemia after the initial resuscitation, especially maintenance fluids in burn patients. Sometimes some people have also demonstrated the efficacy of permissive hypovolemia as the concept of permissive hypercapnia. Well, I could come across only one study in which it was an observational study in patients undergoing major abdominal surgery who received either 0.9% saline or a balanced crystalloid solution that was plasmalite on day of surgery. The in-hospital mortality was 5.6% in the saline group. It was 3% in the balanced group. The complication rate were more or less similar in both the groups, but post complications were more frequent in the saline group, which include renal failure, blood transfusion, and electrolyte disturbances. So Isolite P can be used in patients, especially for in-surgery patients. Coming to colloids, colloids solution consists of homogeneous, non-crystalline, large molecules or ultramicroscopic particles dispersed toward another substance. They could be blood derived, which includes albumin, plasma protein fraction of fresh frozen plasma, or semi-synthetic, which includes hydroxyl, starch, dextrans, and gelatins. Advantages: they expand the plasma volume more effectively. It leads to preservation of intravascular cardiac pressure and prevent extravasation. Albumin, the reference colloidal solution. It's expensive. It has a limited availability, but there was a Cochrane review in 1988 which showed that administration of albumin was associated with increased risk of rate of death as compared to saline. But this Cochrane review included only a small number of studies till 1988. Largest study to date, where there's a comparison of albumin with saline for fluid resuscitation, that the same study was published in NAJM in 2006 or 2007. The blinded randomized controlled trial, which included about 7,000 patients in ICU. Resuscitation was done with 4% albumin compared with 0.9% saline, and rate of death was measured at 28 days. There was no significant difference between albumin and saline with respect to rate and death. So the investigators are very happy. But further subgroup analysis was published 2 or 3 years later. There was significant increase in the rate of death at 2 years on patients, especially with traumatic brain injury. And this was related to the increased intracranial pressure, particularly during the first week after injury. So, albumin has to be used cautiously in patients as a resuscitating fluid. Coming to semi-synthetic colloids, hydroxyethyl starch, I have used HAS for any of the newer ones like Iacmcon when I was a resident. That was way back in 2001. It is produced by hydroxyethyl substitution of amylopectin obtained from these three sources, that is sorghum, maize, or potatoes. And a high degree of substitution of glucose molecules protects the hydrolysis of non-specific amino acids, thereby prolonging intravascular expansion. This is the major advantage of these semi-synthetic ones. The various ones, they are classified according to the molecular weight and the molar concentration, either 10%, 69%, 6%, that is 69%, or 6%, that is 130 and 0.4. And they contain, if you see, this is the human plasma, this is albumin, contains only sodium and chloride, and these starches this contains only sodium and chloride, but this contains potassium, calcium, magnesium, and chloride also. But they have a tendency to accumulate in tissues such as skin, resulting in pruritus, liver, leading liver injury, and even kidney injury. This is more commonly seen in high molecular preparations, which have seen that there are alteration in coagulation and impurity. So, if we have to use, they have to be avoided, but whenever they use, especially surgical patients, reduce concentration 6% with a molecular weight of 130 kD with a molar substitution of 0.38 to 0.45 preferred, and the recommended maximum daily dose is 33 to 50 ml per kilogram of body weight per day. But this was the first study, the Scandinavian group, which compared hydroxyethyl starch versus Ringer acetate in severe sepsis. Again, it was a blinded randomized controlled trial, for 800 patients were studied. As compared to 6% hydroxyethyl starch, when compared with Ringer acetate, there was significant increase in the rate of death at 90 days. There was significant 35% relative increase in the rate of renal replacement therapy, that they were more likely to have kidney injury with the use of HAS. Another study, which is the chest study, the chest investigator study, in which they compared HAS with saline for fluid resuscitation intensive care. Again, a blinded randomized control study, 7,000 patients in ICU. HAS was compared with 0.9% saline. It was not associated with increased risk of rate of death in 90 days. but there was significant, that is 1% relative increase of renal replacement therapy in the HES group. And they also found that blood products used was increased in the HES group as compared to the normal saline group. Coming to the newer semi-synthetic colloids, that is Iacmcon and Gelfosine, I could come across only one study where they found in HES, Iacmcon and saline, acute injury occurred the maximum in HES. 68% of patients receiving Iacmcon and 47% of the patients receiving crystalloids. But the mortality was more or less similar in all these groups. So as a crux, I would say crystalloids are preferred IV fluids in PCUs as compared to colloids. You can't keep on giving steroids, fluids. You have to measure how much to give, when to stop. Though survival sepsis campaign says 3-hour bundle, 6-hour bundle, but you don't want the patient to go into fluid overload. So the CVP is required. But this study from 2011 showed that when the CVP was less than 8 and when the CVP was 8 to 12, the mortality was much lesser as compared to CVP which was more than 12. But by day 4, the mortality was more or less in all these 3 subgroups. This was a meta-analysis which included 24 studies. Overall, 56 and 16% responded to fluids. Baseline CVP in responders was about 9. In the non-responders was also around about the same, that was 9.7. And authors concluded that there was very poor relationship between CVP and blood volume, as well as the inability of CVP to predict the hemodynamic response to a fluid challenge. So they concluded that CVP should not be used to make clinical decisions regarding fluid management in patient sepsis. Pulmonary catheters, a very quote-unquote glamorous way to monitor fluid therapy. But this was a Cochrane review, 13 studies comparing patients treated with and without use of pulmonary catheters. Total of about 5,600 patients included. No difference in patients who had either PAC inserted or who did not have a PAC. There was no difference in the number of deaths, no difference in days spent, no days spent in the hospital or in the ICU, but there were more complications in the patients in which a PA catheter was put. It was procedure-related complications that added to the cost. So again, this Cochrane review concluded that there is no indication of putting PA catheters for fluid monitoring in patients of sepsis. So how else can we monitor? Survival sepsis campaign investigators have said that you can use mean arterial pressure. They said that mean arterial pressure is more than 65 millimeters of mercury, but the study which they quoted included only 10 patients. And it can have abnormal values, especially higher values in patients with hypertension and atherosclerosis, or lower values in patients with baseline normality. So we can't rely entirely on mean arterial pressure. Then the concept of mixed venous oxygen saturation or the central venous oxygen saturation. What is the difference between two? The first, that is the mixed venous, it reflects the percentage of oxygen bound to hemoglobin blood returning to the right side of the heart. We measure it from the tip of the pulmonary artery catheter, normally between 70 to 50%. But the central venous oxygen is obtained from the internal jugular vein or subclavian vein if it has been put. The normal is between 70 to 70%, and it generally reflects whether the cardiac output and the oxygen delivery is high enough to meet the patient needs. And if we see what determines both of these is the oxygen delivery, that VO is the oxygen delivery and VO is the oxygen consumption. Anything which increases the oxygen delivery, that is increased oxygenation, increased HbA, increased cardiac output, increases both of them. So can I use this information clinically? Studies have shown that both of them are equally efficacious, and if whenever possible, any of them can be used for monitoring fluid amount. Lactate. In the latest surveillance campaign, they have emphasized on the role of measurement of lactate as a measure of when to stop and when to give fluids. But lactate, as close in septic shock, increased production because of tissue hyperperfusion, tissue hypoxia, and because of reduced metabolism because there is hepatic or renal dysfunction. Intestine 1 is normal, 1 to 2 is concern, more than 2 is bad, and more than 4 is very bad. There is a term of lactate clearance. After initiation of fluids, people have shown that if the lactate levels return to normal within 24 hours, the mortality decreases substantially as compared to individuals, patients in which the lactate levels do not fall back to normal within 48 hours. So this is the bar graph showing the both graphs. So more confused, which to use, lactate clearance, mixed venous oxygen saturation, or the central venous oxygen saturation. In this study was a randomized controlled trial. They had 150 patients in both the central venous oxygen group and the lactate clearance group. 34 patients in the central, in which the measurement of the central venous oxygen group died as compared to 25, more or less the same. There was no significant concordance in achieving lactate clearance and the central venous oxygen goals when measured simultaneously in the same subject, summarizing that lactate clearance and the central venous oxygen consideration therefore are complementary and are not mutually exclusive. That is, you don't need to measure both of them in each patient. You can measure either of them. But important to remember, sequential periodic examination of the patient is of utmost importance. Forget the no-touch technique. You have to measure the pulse, you have to touch the patient. You just can't look at the monitor to manage a patient with fluids. I thought I'll touch 4 diseases of fluid management. I have about 3 minutes. I chose 4 diseases like sepsis, diabetic ketoacidosis, surgical patients, though I did not, it was a topic by itself, and lastly dengue. In all these 4 conditions, fluid therapy is of utmost importance. So I thought individually I'll take one by one or 2 slides. There's a grading system, as you all know in survival sepsis campaign. Depending on the grades, you can have importance, which is more important, which is less important. According to survival sepsis campaign, there should be no delay. It is a goal-directed therapy. There is a 3-hour bundle and there is a 6-hour bundle. There should be no delay. There should be a protocolized approach in managing sepsis. Elevated lactate levels more than 4 millimoles per liter identifies tissue hypoperfusion. The goals of the therapy with the first 6 hours are the CVP of 8 to 12, mean arterial pressure of more than equal to 65, and journal output of 0.5, more than 0.5 to 1. And the CVP at the central venous or a mixed venous oxygen saturation of more than 75 or 60%. They say the fluid should be crystalloids. They're against the use of hydroxyl starch. Albumin may be used in specific conditions. A minimum of 30 ml/kg of crystalloids may be used. And fluid administration to be continued as long as there is a hemodynamic improvement either based on dynamic or static variables. Always you have to monitor or reassess the patients very carefully. Fluid therapy in DK, first don't go for a CVP. Put in a large bowl, preferably 2 lines. It is said that the average adult patient, the water deficit is about 100 ml per kg and a sodium deficit of about 7 to 12 milligrams per kg. It's a very busy slide. They say within the first 1 hour, 1 liter of normal saline or fluid should have gone in a DK patient. And then depending on the potassium levels, you will decide whether to give insulin or not. And within the first 2 hours, 2 liters of fluid should have been pushed in to that DKA patient. Because fluid, it is not insulin. And the second most important parameter for managing DKA patients is potassium. Insulin comes later. Surgical patients, ringer lactate is preferred over saline except in cases of hypochloremia. Dextrose saline or 5% dextrose sources of free water meant for maintenance to be used in caution the children and elderly. Maintenance requirements of sodium of 50 to 100 millimole per day, potassium of 40 to 80, in 1.5 to 2 liters of water. Fluids and surgery are a topic by itself. So this is the summary of 3 or 4 points of how to give fluids in surgical patients. Lastly, fluid therapy in dengue, which is of utmost importance. This capillary leak. So if whatever fluid you give would go into the third space. So this case definitions of dengue, that is severe dengue, that is A, where there is dengue and warning signs, and B, where there is severe dengue. Warning signs are abdominal pain, persistent vomiting, clinical fluid accumulation, mucosal bleeds, lethargy, liver enlargement, a laboratory increase in hematocrit. This is the first sign of capillary leak. This is the most important. This increases even before the platelets rise. So this we have to monitor as clinicians and patients of dengue. And whenever you have any of these warning signs,